Beautiful. Thank you so much for having both Paris and I. We are really stoked to be invited. We are so passionate about education in this space, especially just because oftentimes the people that we speak to feel like they completely walk this path alone, and you definitely don't need to. So we're very stoked. We also, a lot of the work we do is very evidence based. So typically the things we are recommending are backed by our extensive research that we do over the assessments that we complete. So we are all for the highest of quality continence care. So we'll quickly touch over what a continence assessment actually is and sort of the parental role with the assessment, how it could be funded. You've got sort of two types that you can access for that. We'll define continence, go through some strategies and some of the market consumables that are currently on offer. So continence as an assessment is really just that structured evaluation where we're sitting with you to understand the type and severity of the individual's incontinence. So that really just means any form of loss of control, whether it be sort of a more minor, mild control or a complete incontinence of the whole bladder and bowel. It's typically carried out by nurses. You can get some more highly specialized continence individuals, but you wouldn't really typically see a urologist for the base level continence assessment. But we do love to have them involved. The goal is to just identify what the underlying causes are, determine where the best management is going to be for the individual, create a bit of a treatment plan, and then really ultimately try and improve that individual's quality of life. This may also involve, and typically almost always involves, recommendations for referrals to additional health professionals. We are one small component of continence, and we really like to collaborate with physios, OTs, GPs, urology, all of that to ensure the most holistic practice. When we sit down, we assess pediatrics all the way up to elderly. So the continuum of people is really quite large. So the questions we ask change almost every day. I'm sure Paris probably asks one different question at least every assessment she's done lately. We start really with the history. We get to know the person, the individual. The family structure as well is really important, especially when we're talking more about our pediatric children. Look at what the current challenges are. We don't really want to know just immediately what the goal is. We want to know where you're currently at. We meet you where you are. Then we'll go into specifically more so developmental history for our children. We really want to know from birth to 5 years what's going on. If they're not yet 5, where are we at? What have we trialed? We want to know the physical, the social, the emotional, the sensory. We want to know it all. Then we'll ask about the goal. And from there, we really try and tailor it to be a very goal-centered assessment. And that's our why. Why are we doing this? Why did we meet today? I always like to ask, what drove you to make this referral? Why do you need us? Then we like to know about previous strategies. We have had so many individuals who have 2 pages worth of strategies that they've tried, and we often leave the assessment going, you've done literally everything possible. But then we also have individuals who have no idea what to do. So we talk about maybe what they've trialed, where their successes happened, where their downfalls, where their regressions. Then we'll talk about what they're currently using, nappies, wipes, creams, everything, what's working, what's not. What's not working, we want to know specifics. Is it leakage overnight? Is it size? Is it discomfort, rashes, anything like that? For children, we also like to talk about temperament, not really something we always speak about with adults, but for children, and then being mums ourselves, we know temperament drives our children. So we want to really understand what motivates and drives them. And then we also really set some really low expectations because it leads into a longer term success. Parental role is a really big one. I would probably say about 98% of the pediatric assessments we do are done on the behalf of the parent. Most of the time the kids are at school or nonverbal, so we really get that complex understanding from the parent themselves. They know their child best anyway. So we'll set the assessment and have the appointment. They will be implementing the strategies. So we really find oftentimes the assessment is more for the parent than for the child, and the child ultimately achieves the success out of the parent's role. We approach it with consistency is key, but being mindful to be child-led. I'm starting to toilet train my 2-year-old at the moment, and I know very much so that I can be as consistent as I want, but she's not quite ready. So I have to be hands-off and be led by her. Also about reducing shame. There was a really great continence CPD session last year that spoke about an element how parents can come to continence and the mishaps of inappropriate voiding or inappropriate defecating and place blame on the child as if the child is doing this to them. We really try to work through reducing that shame and stigma that it's not necessarily the child to do this to you, it's happening to them. So we really want to foster a very safe toileting environment and encourage and promote that success at all elements of that assessment and implementing those strategies. We'll do a fair few play-based behavioural strategies. We like to start with behavioural first anyway, and then also role modelling is foundational. So I don't think I've gone to the toilet alone in probably 4 weeks, which is fine because I'm role modelling exactly the behaviours I would like for my daughter to hopefully return one day when she's ready to train. Funding. So, I mean, NDIS is a beast. It's a great beast, but it is definitely a big one. We typically find our continence assessments are funded under disability-related health supports. We've popped up the line item just for clear transparency of what we currently charge under at ILB, just in case anyone's interested in an assessment. We've got great capacity, so we tend to get these done quite quickly. I always recommend, though, funding is a conversation you really should just have with your support coordinator about where you could pull funding from for these assessments. If you're needing to have one done, absolutely just have the conversation. The total that you'd be charged, and this is again just talking for ILV, considers travel time. So I think it's now only a max of 1 hour per participant anyway with the new rules. The length of the assessment, I don't know if we've ever had Paris any go over 60 minutes, have we really?
No, I've done a few that has been 60, but nothing over an hour usually.
Yeah, typically. I mean, and it depends on the complexity of what the assessment needs to be. So it can absolutely go over 60. And then we do research and reporting after that. So our personal assessments typically take about 4 to 8 hours max. Typically, it's really around that 5 to 6 hours, a very sweet spot for us to do the assessment within. So that's a little bit about NDIS side of the funding. The way our reports work is we come out, we assess, we write the report, it gets invoiced. Once the invoice is paid, the report will be sent to you. We typically find the payment of the invoice is what holds things up. So it all has to sort of work really nicely for that report to be given within a week and a half to 2 weeks. We can do follow-on services. We don't typically have many that we do follow-on for, but we can absolutely tailor that, and that's just really our person-centered offering. We don't just stop at the assessment. We can meet you wherever you need to along the journey, especially when we know that around that 3-month mark of success, we can sometimes expect some regression. There's also CAPS. So the Continence Aid Payment Scheme is available for everyone, irrespective of NDIS or aged care funding. It is a government initiative that they've provided that allocates funding for the purchase of incontinence aids. It's 717 for this year, and if I remember correctly, it's given either on an annual payment or biannual payment. The only, I guess, side of that is if it's funded in your NDIS plan or your HCP aged care plan, you won't be eligible for CAPS. You have to be 5 years or older and have an eligible condition. So they aren't really it's very limited in terms of the scope to actually be eligible. And sorry, what I mean by that is there's not that many hoops you have to come through as long as you're not funded in an alternate source like NDIS and you're over 5 years and have an eligible condition, you should be able to access through Medicare, and the form is just on MyGov through Medicare. And I think it's just a GP for you to get that done through. So that is an alternate source, which is great because I only first learned about this when I started doing continence, and 717 is a considerable amount of money to help with the payment of these aids because they are not cheap if you're not funded for them. Okay, now the good stuff. So childhood urinary incontinence. Urinary incontinence is defined for children as day wetting for any child over 5 that occurs more than once once a week, I believe, for more than 3 months. That doesn't seem like a lot, but it definitely needs to be for that 3 months for them to consider it as like a long-term issue to need investigating. We won't take that specific definition, if you come to us as an assessment, we're not going to say your child's not incontinent if they've, this has only been for 3 months. We absolutely are happy to come and meet them. But that is the Royal Children's definition. Bladder capacity, I popped in here because I really thought it was quite an interesting one to recognize. So an adult bladder can hold a considerable amount. It's usually around that 1 litre for females, 1.4 for males. So a 6-year-old's bladder capacity can only hold up to 240 mils of fluid, which I think when you actually think about that being, I think that's about 1 cup of fluid, which is a really small capacity. So you can see why if we're like filling them up with fluids, or they're drinking and then they're incontinent, that bladder capacity really does matter. And then as they age, the bladder capacity gets larger. Why are kids urinary incontinent? Well, I mean, I should have put here the first point really should be sometimes we actually don't know. You can't always find out. Sometimes they grow out of it. Other known cases are overactive bladder, or OAB, which is a sudden and urgent urination. Usually they're like, oh, I've got to go. I've really got to go. They get panicked. They've really got to go. And there's a short window of time to get them to the toilet before they'll be incontinent of typically their full bladder. It's typically associated with an element of frequency. So they'll have a really sudden and urgent need to go very often. We would probably say that would be more than 3 times in an hour. I'd be like, that's a bit abnormal if you're doing a full volume void. So if you have those sort of 2 symptoms, you're starting to think, okay, is the muscle of the bladder overreacting and so overactive that any little volume of urine inside the bladder triggers it to squeeze out and want you to go? Habitual delay, which is really another term of sort of delaying a void, which void is another word for urinate. So kids are really known to have habitual delays because of fear of missing out. They don't want to miss out on their show, their school, their play with their friends. They'll delay going to the toilet because they don't want to miss out on lunch. And that then leads into an overfilling again of the capacity of the bladder and then leaking as well. There can also be underactive bladder that leads to more infrequent urination. So if you're not emptying the bladder, the same thing occurs as habitual delay. You get overfilling and overflow. When they laugh, they might leak, and then it leads into a whole volume void. And then there's also dysfunctional voiding, which is more of a physiological issue, which we personally can't really do much with. We can just then recommend that if we believe that there's a bit of a dysfunctional voiding issue, that you'd seek GP advice to then get a specialist referral. And really that, I like to think of the bladder as a balloon, and the end of the balloon that you blow it up from is really where your bladder sphincter is, and it has to relax in order for you to empty your bladder. So if there's an inability to relax that sphincter, they're only going to open it the smallest amount for the urine to actually trickle out. And then oftentimes when you're only partly emptying your bladder, you have a higher risk of urinary tract infections. So if your child is also getting significant and regular urinary tract infections, it's worth having a look at how much they're actually voiding each time they go to the bathroom.
Which I will also add, urinary tract infections in children are not common symptoms like it is for adults. A lot of the time they can have a UTI and you won't even know. So it is something worth getting looked at if you are noticing that they are having more frequent episodes of incontinence, even if, especially after toilet trained.
Absolutely, yeah. Nocturnal enuresis is then the nighttime wetting. So that's just really the fancy name for bedwetting. So bedwetting is defined as urinary incontinence overnight, specifically in school-aged children. The school-aged children part is pretty important to note because we do sometimes see children around the age of 3 and 4 who are wetting overnight. And we just sort of set a bit of an expectation that that could just be an age-related milestone that they've not yet reached. So really any child over the age of that 5 to 6, we would expect to be dry overnight.
I'd say the average is about 7 years old.
Yeah.
And then with our kids with developmental delays, it can be as old as 12.
So that's exactly why we like to just really meet the child where they're at the time, is it's very common. I think it's including children who are traditionally trained during the day. There's a little bit of a stigma around being trained in the day should lead into being trained at night. And it really actually is being trained overnight is the last really I believe it's the last milestone, isn't it? Really, Paris, other than bowels.
Yeah.
And I think that really goes back to, for all children as a baseline, the physiological capacity of your bladder to hold 240 mils. We all continue to produce urine overnight. So your bladder really needs to learn to stretch to hold the urine. So we don't expect children to just be trained instantly overnight. The causes for bedwetting specifically are a little bit different to daytime wetting. So it could be genetics. Family history is very important. How often did the parents, when were the parents trained overnight? Some of us might not remember, but any older siblings, it's really important to know. Small bladder capacity. So we may sometimes even request that you go and get a little bit of an ultrasound to see how large the bladder is when it's full. But if you've got an inability to store the required volume overnight, it'll just lead into overflow. Sleep disorders is a really common issue for children. If you've got like even a sleep apnea child or just a child who's on any sleep medication, it's not unexpected for them to have some mild to moderate incontinence at nighttime. If the brain can't wait to rouse to a full bladder, it's not going to happen and they'll just end up wetting and having overflow. So we sort of also look at more of those sedative-based medications for overnight wetting. Excessive urine production. So if you've got an excessive amount of urine produced, and it's not just from an overconsumption of fluids close to bedtime, but it can happen to some children, and it is related to the next point, which is hormones. So overnight, all of us will release a hormone called vasopressin, which is an antidiuretic hormone, which tells our brain and our bladder essentially to reduce the amount of urine that it makes, concentrate it, so then we don't have to make as much so we can store more essentially, and then hold on till we get up in the morning or overnight. Some of us still do. So that hormone is commonly actually really undersecreted in children. It's not our first always thought that it's going to be undersecreted, and that's why we're having wetting at night, but it definitely is where we have to go when all of the other behavioral side effects and strategies have not worked. Constipation.
Yeah. Hormone, sorry, Abs, that is usually the main contributor to bedwetting up until that age of 7 and 12, obviously, because if your body's still making the hormone, then you're going to wee at nighttime. So until your body can stop the hormones of balance, then you will not make as much urine at nighttime, and then you won't bedwet. But if you are still doing it, then there's nothing we can do about that, unfortunately, unless they're over that age.
Yeah. And if it's a continual issue of undersecreting, you can get medication to replace that. That then is moving more into that specialist referral, which we absolutely can advocate for. Constipation is a big one, which we'll touch on. I won't touch on that now because it's quite important further on in the presentation. And developmental delay, as Paris said, overnight wetting up to 12 is not uncommon. And that is, again, a whole other broad range of contributing factors. So symptoms of urinary incontinence. So absolutely no period of dryness. Continuous dribbling is also an issue. If you're noticing your child's underwear is consistently wet, we would want to know about that. What's happening? Are they dribbling? Are they going to the bathroom? Do they need to double void? We want to know voiding frequency, urgency. We like to have a bladder diary done. It's really detailed to know how often and how frequent the child's going to the toilet, for how long they're going to the toilet. Witnessed holding maneuvers. We love to call it toilet dance. So is the child bouncing around, pulling at their pants, crossing their legs, becoming really fidgety, trying everything not to go to the toilet? Dysuria is then also related to that bladder diary. If you put 2 entries on a bladder diary in a 12-hour period, we'd be a little bit concerned for that. And then a presence of comorbidities for other symptoms would be constipation, UTIs, nighttime wetting, and increased urination, which can also be due to having renal disease or diabetes as well. Treatment. This treatment and strategies is specific to urinary incontinence. We will talk about the bowels in a moment. Regular voiding schedule. For our kids, it is really important to have timed sitting schedule, but not really more than, I wouldn't say like 3 or 5 minutes. Would you, Paris? You wouldn't, like 3 minutes probably? Yeah.
Get bored after that.
They get bored, their pelvic floor doesn't relax. It can be, a worst case scenario, you end up with hemorrhoids, especially as adults. We do not recommend sitting on the toilet for more than, 5-10 minutes max as an adult. So regular voiding, the best time to go to the bathroom for both bowels and bladder is 30 minutes after eating. So your body has an intrinsic mechanism called the gastrocolic reflex, where when you've chewed, the process of chewing, eating, digestion triggers your bowels to want to open, and same with voiding 30 to 60 minutes within eating. So we're trying to really get those kids on the toilet right after breakfast, before leaving the house, get a little bit of a schedule going so it becomes predictable. So most kids, not all, respond quite well to that predictability. We use star charts on the fridge, anything that you need to, timers, things like that, to really get them on that time sitting. Bladder diary, we love to know it, when you've gone, how often. We do it for about 3 days at a minimum. 7 days is the best. Sometimes when we're seeing individuals we've not had very long since getting the referral, we'll see you quite quickly, so we don't always get a really comprehensive bladder diary done. Bed alarms. We might talk about bed alarms a little bit down in the consumables, because we do have a few photos of them, but they are a really gold standard for overnight weddings specifically. So it is essentially an alarm that can be placed on either the sort of pajama pants or the underwear, or it can be a bed pad. It alarms when it detects fluid. What we would require for a bed alarm to do, and this is about an 8 to 12 week process, so it is really, a whole family has to commit to it. What we would expect is that when the alarm goes off, irrespective of the child being completely saturated, they still go and sit on the toilet. And it's trying to get their body in the habit of waking to a full bladder and going to the bathroom as they need it. People have mixed reviews about it. It can really work, but you can also get some regressions from it, and the family has to really be on board. So there's a lot of sort of social and emotional education that has to happen with that. But we're really lucky that there's a lot more convenient options coming out. I know the Midnight Gang are starting to stock daytime alarms, which can be, they're small, very convenient alarms that can be worn for kids who may still have the occasional accident during the day. Ample fluids is actually one that probably some people wouldn't expect. You would almost feel like if you're pushing fluids into your kids, they would be urinating more frequently, but we want the bladder to be happy. A really dehydrated bladder that runs on minimal fluid is a very irritated, angry bladder, and that's when you're likely to get those constant contractions of the bladder. Any little amount of fluid says, I've got to go to the toilet. So we want you to really be constantly flushing out that bladder, making sure it's happy, it's full, it's stretched to the capacity that it should be stretched to, and then it contracts when they're ready to void. We love our GPs. I think GPs should be involved for everything. I always recommend take my assessment to the GP, speak about it with them, have them look over it, get their opinion, get them to add in any of the referrals that we might have suggested. This again is exactly where for the hormonal and sleep disorder evaluation would come in as well. Footstools are great. Footstools and pelvic floor therapy are very hand in hand. We love for a footstool to give you the correct posturing. It depends on the toilet mechanism that you're using. If you're still using a potty, you don't need to use a footstool. A lot of the potties that sit over the toilet already have the footstool, which is great. But if your child's big enough, or if they're even a young adolescent to use, I would highly recommend a footstool. For the alignment of your spine really opens up the pelvis for easier passage of stools, but also more comfortable voiding. If you're like hunched over with your elbows on your knees or just upper thighs, you're squashing your bladder and it's just really not going to empty properly. Pelvic floor therapy, I'm going to say this on behalf of all ladies, especially those who have had a baby. Pelvic floor therapy is exactly where we're at. I think everyone probably should be seeing a pelvic floor therapist at least once or twice in their life if they are even very well continent. And pelvic floor therapy isn't just for adults. We have a really great connection with pediatric pelvic floor therapist who gave us really valuable tools to understand how the pelvic floor is actually related to the whole body and your development in fine and gross motor skills as well. So they are really key allied health professionals for us to collaborate with. Focusing on body awareness. So your child's body and their ability to recognize where they are within their body is very important, because it helps for them to recognize tummy pain is me needing to do a poo, or my tummy pain and my fullness in my bladder is me needing to do a wee. And looking at the developmental milestones, I think even the children with developmental delays absolutely have a place to look at their continence with where they're at. And that's, again, us meeting children where they are, with whether that be a really complex history of developmental delay or being slightly just behind. Every child has a spot on that continuum. So seeing where they can grow in their body awareness is a really great key strategy to hopefully enhance their urinary health as well as their bowels. And role modeling is a really key strategy as well. So talk it through. I often find myself going, oh, I can feel it in my body. I need to do a wee. And I think the slow, repetitive, I feel so silly saying it, but I think slowly and more repetitively, I'm starting to see my child pick it up. And it's just become a common thing now that I do. So I think role modeling is really, really key, especially with younger children who may not even be ready to toilet train. I would start it well before you think you might need to be training. I might hand it over to Paris to talk about the fecal side of things, and then we'll go into consumables.
All right, sounds great. So fecal incontinence, or encoparesis, is the technical term for it. So children over 4 years or older cannot control when or where they need to defecate, defined as regularly defecating in places other than the toilet. So, yeah, refusing to use the toilet as well, hiding, and wherever they want to go. Most commonly we find that it is constipation, and then you'll have that sort of overflow effect from a backlog of stool sitting there. So pooing places other than the toilet. So you have a lot of kids hiding and pooing, or pooing and then fecal smearing as well is quite common. They'll poo in their hands. Pain, large or hard stools, significant avoidance or fear of going to the toilet for pooing specifically. You might have a lot of kids that will go to the toilet to urinate but will not go to the toilet to open their bowels. And a lot of the time when they have fecal incontinence, they do have urinary symptoms as well, just from that constipation. Abby, flick through the page. Thank you. Functional constipation has a set criteria to be able to diagnose it. So you have to have 2 or more symptoms for more than 2 months, 2 or less stools pass per week, history of retention or complete emptying, history of painful hard bowel motions, history of large diameter stools, presence of large fecal mass in rectum. At least 1 episode per week of soiling after successful training is also additional criteria. So you can have kids that are toilet trained, but they are having this functional constipation. That's very normal due to the refusal to wanting to use the toilet. And then they might actually open their bowels on the toilet, but the functional constipation is still a problem that needs to be addressed. So the withholding cycle is that functional constipation. So they'll hold and hold and hold and they won't go. And then a lot of the time you do see the overflow diarrhea, because there's obviously, it's got to go somewhere. So I've had kids that will not open their bowels for up to 2 weeks at a time, and then they're having these really hard, painful stools, and they're having lots of that smearing in their underwear in between these toileting times, and it takes a long, hard go to get them out of this sort of cycle of withholding, but a lot of the time it is sensory preferences, long-term constipation before age of 4. So those kiddos that are having constipation from when they're babies, that's a big flag for us as well. A lot of the time it's not something that just comes on randomly, unless there has been some sort of trauma or something like that, then that can lead to it. But a lot of the time I'm finding that these kids have been constipated basically since birth, and then you can obviously have some sort of physical abnormalities as well that affect that, but that is the case a lot of the time. You have the kids that don't want to miss out on anything, so they won't go to the toilet as well, which obviously doesn't help. But a lot of the time it is a bit of a sensory preference with the toilet, whether that's the actual toilet itself or the toilet paper with wiping.
And I think we find as well, a lot of the kids doesn't actually matter if there's a habitual pattern of withholding. the cycle just continues to go, and it's mostly related to like the pain of the bowel motions. If any of us do anything painful, we're not going to want to do it again. So as soon as kids do that, then they withhold, but then having to try and pass the stool that they've withheld is painful. So then it just keeps going in a circle.
Yeah,
It's
and
really
a lot of things
difficult.
with the medications that you then have to take to try and combat this cycle. A lot of kids don't like them because they don't taste very nice, so then they won't take those, and then
Yeah,
the cycle just persists.
and there's a lot of fear and shame that is given to these kids, because a lot of the kids, especially at school, are fecal smearing. So then they smell at school, then they're bullied, and then they just continue to withhold. So it is really the crux of the whole encopresis.
So yeah, there's a big list of treatments and strategies that you can go through. We like to try and sort it out before you have to go to the hospital, because that is unfortunately where it can end up. So our aim is to break the cycle of withholding, and so sort of foster a good relationship with the toilet, so they're not scared to go anymore, they're not having that pain when they go. So lots of fiber, fluid is really good. Exercise, a lot of the time when you get moving, your bowels start moving, and that's really good. I doubt that that's hard for, I mean, some kids obviously wouldn't be able to, but that's always a good one. Footstool, like Abby mentioned with urinary incontinence, having proper bowel alignment is key. It makes it a lot easier to open your bowels if everything is in the right place. Regular toileting, that sort of time sitting 30 minutes to an hour after meals is uber important. It's the best time to go. So if we're starting even then, even just sitting on the toilet for a few minutes is fantastic. You can, we start somewhere. Involving the child in the planning and the goal setting. So lots of treats for them. A reward chart is really great. Parents know their kids best, so whatever's going to work for your kid, you go for it. Social stories, visual cues, pictures, exchange cards. A lot of the times people like an iPad or something, or a phone. Lots of kids will like to sit and watch a video about toileting. There's lots of good ones. I know Wiggles and things do ones like that at the moment as well. So if your kid's into that, fantastic. If that's going to get them to sit for a little bit longer, great. Emotional support, social support, that's always fantastic as well. Kids are not going to do it if they don't want to. So you have to really kind of go with them, go by their temperament, like we've been saying. Laxatives is usually the biggest one. Help make that stool nice and soft, well formed, well hydrated, make it nice and easy to pass. Unfortunately, a lot of laxatives don't taste very nice. So even the flavorless ones, a lot of kids don't really like, but you can get some good ones. There's chocolate flavored, and, we try and there's lots on the market, so we can go through every single one to try and see what is going to work for them. Good thing about laxatives is you don't really need a prescription for them. So we can kind of suggest what ones we think best, but obviously being a registered nurse, we can't actually prescribe anything. But we always just suggest these. Chat to your pharmacist, chat to the GP if you're feeling like you need to have some further clarification on it as well. X-ray may be required. That's kind of if we're going into sort of the hospital setting. And then, referral to specialist, and inpatient disimpaction is this for the severe cases. A lot of parents obviously want to avoid that because it's quite full on. But that's what we're here for, to try and help stop getting to that point.
Yeah. I also think I forgot to add into here, to keep going when the laxatives work. Really common for us to see families go, we tried the laxatives for 5 days and we just had this mountain of accidents and diarrhea, and it was such an issue. And it's sort of then reframing that thought to actually be, that's the bowel clearing out. You have to kind of get through it. The disimpaction process in hospital, recommended by Royal Children's Hospital, is adult doses of Movicol. So you could imagine on a little tummy, it is an insane process to go through.
That massive clear out, and then you kind of have to have what we call like a maintenance dose of laxatives therefore afterwards, because their bowels just haven't been working properly. So you kind of need to get everything into a bit more of a rhythm, and then you can wean off eventually, but they're usually on those laxatives for quite a while. Yeah.
And don't just stop them. If there's diarrhea, don't just stop.
Yeah, so continence and comorbidities, so that's kind of where we are at the moment. Continence isn't just as easy as what people think it is. A lot of the time there's lots of background information that are causing it. Childhood incontinence especially is very complex. It's not as easy as adult incontinence. It's a lot kind of more clear cut with adults why they're being incontinent. So we kind of, we do an assessment. GP specialists can implement our suggestions and then kind of add on if they need to. We always like to go with our allied health professionals as well. OTs are amazing at helping with toilet training, especially behavioural therapists as well. Obviously, they're really good for our sensory preference kids that don't like the toilet paper, or they don't like the sound of the urine hitting the water in the toilet is a big one as well. So they're the people that we reach out to. And a lot of the time these kids are already seeing them anyway, and they just tack this on to everything else they're kind of doing. And then we obviously we recognise that carer burnout's massive, especially with everything else going on, and then you add in incontinence. So it's really good for you guys to have mental health support as well. And like we've said, recognize that your child's not doing this to you specifically to be nasty. They don't have control over it. So we obviously begin with our continence assessments. We identify our strategies, implement the behavioural and lifestyle first. So that's our diet, our habits, posturing, so your footstools, using a potty if you haven't tried that, or a toilet seat potty, the ones that go on the toilet. You can get good ones now that are built into the actual toilet seat, so you kind of just flick it up if your kids are that little bit bigger and can kind of just use a stool on top rather than having this big clanky thing that sits in the toilet. And encouraging and supporting our growth, spine and motor skills. So there's a really good resource on Continence Australia's website. I think it's called One Step at a Time. It's a really good information pamphlet, booklet sort of thing. It's about 60 pages long, and it goes through what to expect with toileting when your child is developmentally delayed. So it kind of goes through a bit of like a checklist sort of thing that says, okay, can my child get themselves dressed? Because that is a massive motor skill that's needed for toileting. So it kind of helps you navigate it a little bit, whether they're completely ready to start toilet training or it's not even on the books. So that's always a good one I like to recommend to read through. Medical review, so GP for constipation management, that they need the involvement in that, especially we're having these sort of large doses of laxatives. That has to be kind of recommended by a GP. Disimpaction process, like we've said, they do recommend to trial it as an outpatient first, and then if we're having these problems, then we move into the hospital environment. Preventative laxatives, ongoing dynamic changes, meet the child where they are and adapt to them. So our current consumables, so I'm sure a lot of you are well up to date with what's on the market at the moment. And we know that there is a big gap in the market for nappies for those older kids. They kind of stop at a size 6, I think, or a 7. With those tabbed ones especially, they don't really go any bigger than that. So and then you're going into adult sizing where it's all just out of whack and not good for kids. So we've just got, your regular pull-ups, and you've tabbed all-in-ones. You can add pad inserts as well. There's good ones for kids. We've got our toilet training undies, so you can get them from lots of places now. Connie Kids do really good ones. Bonds do really great ones as well. You can get them in most places now. Kmart, they do them everywhere. They're really good for those sort of in between when you start toilet training. They can catch sort of a little bit of leakage without going through to your clothes, but they're a good one. Those oopsies heroes are the bedwetting alarms that we were talking about. Midnight Gang stock them. They're really good. They're also app accessible as well, which is really good. And I think the app makes it kind of fun for kids as well. So that's always a good one. And you can see the photo next to it. It just attaches to the front of the underwear, or you pop it on the pajamas. And yeah, just detects when it's wet. And I'm assuming the daytime one's the same. I haven't really read much about that.
Yeah, I believe they're the same, very small, and they just hide away.
Yeah. Yeah, they're really good, those ones. Some of them can be quite not bulky, but obvious. So those ones are good because they're just kind of tucked away, and then kids don't have to be embarrassed about it. And then we have our bed pads as well. They're fantastic. You can get the ones that tuck in or the ones that just sit on top. I always like to recommend the tuck in ones because they're just better. The ones that don't have the tuck-ins on the side are very annoying. They slip around. My son's always gets tangled in his sheets, which is not ideal because when they, wet at nighttime, then it goes everywhere where it's not meant to. But you can get really good prints as well for those as well. Midnight Gang do a really good print that's pretty. A lot of them are, plain boring colors. So that makes it good for kids. You can get full waterproof bedding now. So that's your sheets, pillows, pillow protectors, doona protectors to go over the top if you're finding that they're wetting through that much that it's going through to the doona. We want to try and protect all our products as much as we can. So mattresses are quite expensive, mattress protectors, all that good stuff. And they come in really nice bamboo and good materials now, cotton, so that you're not getting too hot, because a lot of the problems a while ago was that our waterproof bedding was sweaty, so people didn't want to use it. And then on the end there, we have Kiki Squirt, which is an amazing brand. I love them. My son loves that brand as well. It turns all toilet paper basically into a wet wipe, and it can be flushed down the toilet. So you just spray or pump a little bit onto your toilet paper, and makes it so much nicer on your bum. Obviously good for everyone, but it's really good for toilet training as well, because like I said, with that sensory with the toilet paper, a lot of people don't like it because it's quite rough, whereas this makes it nice and smooth for them. And then you just have your usual wet wipes, baby wipes, your flushable wipes, and all your creams and good stuff as well.
Perfect. So if that is a lot of information, absolutely. So we would actually probably recommend to everyone the best place to go is to start with an assessment. That's not a referral grab at all. That is really just to say there's probably 4 to 5 hours worth of information we could talk to you about based on where your child is at, or even if it's just for yourself. So the best place to start is to call us or submit the referral. You can do it through us or any continence assessment professional.
You jump on our website specifically. You just put in like a little online one, and Jackie, our client liaison officer, will give you a call.
Then we typically book you in. It's most likely going to be with Paris. She is in the role at full capacity, whereas I stepped aside recently. So she will absolutely most likely be meeting you. If it's not Paris, it will be me. So you'll get assessed. We typically write the report. We're pretty ahead of the industry standards. So our reports,
I think our turnaround time is about 2 weeks at the moment.
Actually, if not sooner. Less. Absolutely. Yeah. So we would probably have the report written on average about it within the 5 business days. A bit trickier with Christmas, but absolutely can get it done. Then the invoice is paid and the report's delivered to you. So that's the admin side of it. And that's sort of how that works.
We are pretty good at, if you're having an urgent assessment that needs to be done, we can squeeze them in as well. We're pretty good